right, we'll begin with the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right, morning everyone, welcome. It is May 13th. This is the Shawnee County Board of County Commissioners work session. A couple items on the agenda today, and we will dive right in, welcoming Vallejo for their quarterly report, I believe is what we're doing. So, Bill.
Thank you, Commissioner. Appreciate you. Good morning, Commissioner Rippon and Councilor Eckert. How's everybody this morning?
Doing great.
We'll jump right in here with our report, and of course our time is yours. We'll stand for as many questions as you may have. I want to introduce a couple of our governing board members, Linda Oakes, Dick Klein, individuals well known to this august body. We turned in our annual report for calendar 2023, sent copies of that in, provided copies to Jennifer, and so that is filed per the regulation and statute. This is one of our kind of, I call them quarterly reports, but you'll notice by May 13th, really not a quarter. Just try to get in here, every 2.5, 3 months and make a report, answer your questions, and keep us all moving forward. So the 2023, calendar 2023 corporate audit is underway now. That'll be, what is this, May? It'll be finished up probably in June. I think the board will probably be able to consider it and adopt it in June, but just as soon as it is, like the very next day, we'll get it over to Jennifer's office and get the 2023 audit filed. The expenses are listed there in the second bullet under funding highlights and for the first quarter, expenses and the revenues. And then we want to note that KDADS has once again stepped forward to help us with the uninsured who seek crisis services with some supplemental funding there. The Vallejo Foundation has awarded us funding for our warming center, also a cooling center. That's a community-wide project that we participate in to help individuals who are unsheltered when the weather turns dangerous. The last time being the extended polar vortex that lasted something like 13 days or so. The rescue mission, Topeka Police Department, and others, Vallejo, Breakthrough House, others stepped up to get vulnerable people who didn't have a safe place to shelter indoors. I know, I'm not sure what the final count was of unduplicated persons, but it was somewhat north of 250, maybe 300 individuals that found shelter at the rescue mission and at Vallejo. We kept something like 51 people at Vallejo in our crisis waiting room for about 10 days running, and we're able to help them find warmth. And then want to note security benefit, $5,000 gift for our mobile access partnership for supplies for individuals. I will note here that we have been fully certified by KDADS as a CCBHC, and the certificate did arrive late last week, and so we now have that. It'll be properly mounted and displayed. You'll recall that the CCBHC certification is something going on all over the country. Mental health centers like Vallejo, Family Service, the one at Emporia, clear out to Liberal and Kansas City, are all expanding access, providing more services to people, and then Medicaid pays for individuals who have Medicaid paid at cost. And so we've upped our standards and upped our game and have become a CCBHC. Now, we still are a community mental health center. CCBHC status doesn't change anything about KSA 19 and the chapters that apply there. Vallejo is still a community mental health center providing those standard services. The CCBHC designation just allows us to go above and beyond. Provide some data there. One of the big reasons for becoming a CCBHC and one of the reasons for expanding this all over the country under what was called the Mental Health Excellence Act back in 2014, a national act, was to expand access, to open the doors wider for people to come in and get the help that they need. And you can see here that it is working. Double-digit increases in many of our programs. Want to comment on the work of the Intersection Coalition. You can read that there. Working on various and sundry projects where public behavioral health and the justice system intersect. 35 or 40 members attend that meeting pretty regularly. And then we've listed there some of the items that they're working on. At the top of the page 2, competency to stand trial, needs assessment, suicide prevention, one-stop shop, and other kinds of subjects that we've listed there. Then we want to just give you a brief summary there on some of the other activities. We work with KDADS, Topeka, JUMP, and others to develop a crisis intervention center. A crisis intervention center is a very specific service with sometimes it's called a 72-hour hold or 72-hour care treatment act law, where an individual can be detained up to 72 hours outside of a state hospital, most notably at a community mental health center that's met certain standards. We're working on that at Vallejo. We'll be at the Nehemiah event tonight, and then been working with JUMP on that and some others. This crisis intervention center licensing isn't quite done yet. They're making a few tweaks at the state level to get those regulations just right, but those Crisis Intervention Center regulations flow from the Crisis Intervention Act, which I think was approved back in 2017 or so. They've been this pretty complicated set of about 60 pages of criteria that you have to meet if you're going to become a Crisis Intervention Center. So the overall distinguishing thing here is that Vallejo, for many, many years, along with other mental health centers, have been operating 24-hour-a-day crisis residential centers or community crisis centers. They go by various terms. That's where a person can voluntarily stay for half a day, 2, 3, or 4, as a way of just having a chance to get back up on their feet and heal up, mentally and emotionally. It's a way to divert people from an unnecessary placement at a psychiatric hospital, but those are voluntary. So what's been happening lately is that several of the mental health centers, including Vallejo, Kansas City, Lawrence, Wichita, are moving to the Crisis Intervention Center model. So we'll still have voluntary beds, but we'll also have some involuntary beds where a person can stay for a few days. So we're working on that. It's in development. Funding has been set aside by the state for Shawnee County and Topeka to do that going forward. It's a pretty expensive level of care. Doctors, nurses, 2 or 3 staff people working with an individual at the same time, to help supervise and help those folks heal up. So we are working on becoming a crisis intervention center pursuant to the Crisis Intervention Act. Those are very specific things. And we're targeting December. Not sure that will quite work. We were thinking maybe just starting with a few beds, like 2 or 3, but it may be that we will go to more beds than that. That'll take a little more time to build on or build a facility. So again, we're in touch with the state, in touch with JUMP, others, talking with the Topeka Police Department and others about the importance of this project for Topeka and Shawnee County. So it's one of the big deals we have going on right now. So, get to one level with the CCBHC and take on another big project. That's kind of what we're doing and what we're about. So we'll pause there. I know that I'm available for your questions, as are our governing board members. What I forgot or don't know, they probably do. They do a good job representing the city and in many ways the county sitting on our governing board. So I'll sure stand for questions, folks.
The competency to stand trial.
Mm-hmm.
Do you get most of the cases for Shawnee County, or do they go other places? Or
Judge Wright has been leading the way on that, along with Major Phelps with corrections and Brian Cole. It's become kind of a technical thing, and I'm not an attorney, and the people working on it now are. But a local jurisdiction has the capacity under certain circumstances. Of course, I defer to Rich or others, but you can provide competency to stand trial evaluations locally in many cases versus sending somebody to Larned State Hospital. And that's going on around the state, been going on around the state for quite a while. We haven't been doing those at Vallejo. There's not been a need for it. There's a psychiatrist in town that does those, does a great job with those. More lately, jurisdictions have been looking at, can we do what's called restoration to competency? So if an individual is, it's kind of a short story because the long story is pretty technical and legal. I don't think I can stand here and cite it chapter and verse, but the short story is you're evaluated, and if a finding is that an individual is not at the present time competent to stand trial, which is a whole different thing than, you know, the insanity plea and all that. That's just a whole nother thing. This has to do with an individual's cognitive and emotional capacity to understand the charges against them, what defense counsel means, what a prosecutor is, what's the role of the judge, that kind of thing. So if an individual is found to be not competent because of a psychiatric or cognitive problem, then things take place. The individual can be ordered into restoration. That's generally where a trip to Larned State Hospital for that care, that level of care and treatment happens. It can take a matter of weeks or months to restore somebody to competency, then they can go to trial. We've been talking about doing those restorations here locally, and we started a pilot project a couple of years ago with KDADS and Shawnee County Corrections. That was successful. It did some competency restorations. I say we, State Hospital came here and did them. And so at the present time, I don't know that we're doing any restorations at the jail. The capacity is there, but there's a couple, three kind of a regulatory or legal things that a committee that we started through the Intersection Coalition is working through now with KDADS to see how we can do those in a facile manner. But the capacity is there. We just have to overcome a couple of regulatory kinds of things that I don't completely understand because they're legal issues. So that long answer, Commissioner, is yes, the capacity is there. The short answer is yes.
It can sometimes be a bottleneck in the judicial process, especially if they go to Larned, and it just takes a long time.
Yeah.
But who makes the decision if somebody needs to be evaluated? Is that a defense attorney or a prosecuting attorney, a judge? Who makes?
I might defer Rich, or if anybody in the room has a better answer to that.
It's an affirmative defense lodged by the criminal defense attorney.
Okay. There we have it.
So we're working on just trying to see if we can keep things as local. Now, there are some evaluations, and if there is a subsequent restoration, some kind of intervention to restore the individual to the cognitive capacity that we can't do here. You know, somebody with many, many complex needs, for example, they would go to Larned. So the idea is if a case is, I don't want to use the word uncomplicated to give anybody the idea this is easy work, because it's hard work for everybody involved. But if there's work that we can do here, instead of sending somebody to the state hospital, this is to win for everybody. State hospitals they have a tough time hiring staff, just like a lot of us do, and so it's largely been a staffing issue. So I would say, working through a few technicalities here, which I don't pretend to understand. I've just been kind of the convener of meetings lately, and then I let the really qualified people have the conversations and figure out what to do. So I know that Major Phelps is actively involved, Judge Wright, Brian Cole, and others are working really hard on this. So we're trying. So, and then if those can be done, I use the word routinely just because, not to make anybody get the idea it's simple work, but if we can do those here routinely, then Vallejo is willing to help out. There are other people that could do that work. We just want the capacity to do that here. So that's kind of where we're at right now. Good question. Thank you.
And could you talk a little bit about the one-stop shop for reentry?
I can. So I'm going to credit that conversation back to Director Cole, and so if it if the conversation goes back to, and there's a lot of reentry work that goes on at the county correctional facility right now. There's staff working there, every day to help people adjust, as they leave the jail. So when the conversation about building a psychiatric correctional facility, which we fully support, came around, one of the things that Brian and I started talking about was what else could we do to help people adjust as they leave jail. And sometimes you don't find out, maybe just a couple hours and somebody's going to be leaving, so what can you do to help that individual? Other times, the releases are a little more planned, but we began to conceptualize a physical structure, a place where people could actually go through, have various helping agencies, governmental entities, whoever, to be at this kind of a one-stop or reentry shop for people leaving incarceration, going back to the community. Now, it wouldn't have to be necessarily a compulsory thing. They could voluntarily go through this, but the idea of a one-stop was you bring multiple agencies and providers under one roof to help somebody gain quick access to services. So imagine a place where you could go and get signed up for housing voucher, job interviews, detox, or mental health care, or find access to a general practice physician. So that's the idea behind a one-stop. And then some of that conversation is carried over to what else could we do to help individuals who are homeless. And so we've had just a lot of conversations about that. So the idea is that you find a place where people can easily go to. It's free of charge. Maybe people who are unsheltered, people coming out of the jail, people who are new to town, don't know where else to go, people who have questions, just a safe place you could go and get access to the services you need. Food support, food insecurity, access to affordable, healthy food has become an issue in a lot of communities. So imagine a place where an individual at risk could go and get some help just that day. So that's the concept that we've been talking about. In my mind, what spurred all that was Director Cole's leadership with the psychiatric facility and y'all's subsequent support of that. Just got us thinking, okay, if we have people in a place, what about when they leave? What else could we do to put some more muscle and bone and power behind efforts to help them readjust to the community? So we see it as preventative work. If we can help somebody get set up before they reenter the community, or have a safety net, or people around them as they're reentering the community, maybe we can have an effect on, recidivism and other kinds of consequences. So kind of a big deal. I think it would be a great thing for our community.
You mentioned staffing issues sometimes. Is that?
I'm gonna turn that over to Dick. He can who can I kick the can down the road to? No, go ahead, please. I'm sorry.
Oh, I'm just saying, do you have a lot of positions that need to be filled, or is it?
About half as many as we did, 8 or 9 months ago.
So it's
At one
getting
point,
better.
our vacancy rate got up to be 16 or 17%, like 65, 68 open positions. And some of those were new, but not the majority of them. And I think we're down to half of that or less, Commissioner. So I think the vacancy rate now, last time I looked, was 11, 12%, maybe 9%, kind of varies a little bit. And some of those are new positions, but quite a few are just filling, shift work positions, like the co-responder position we've had open on the weekend for a long time. Hard to find a licensed therapist to work on the weekend in that program. Although we had them at our crisis building 24 hours a day, it's just really hard to fill those positions. People who work in our detox program, people with who maybe aren't licensed people, but people to provide care, supervision, technical kinds of things. So just hard positions to fill. So I think we're down around 9-10%. So a lot of progress there, though.
I don't have much else, so thank you very much.
Okay. Thanks, folks. Take care.
All right, we will turn our attention now to the fiscal year 2023 final ambulance compliance report and 2024 EMS week announcement.
Morning, Commissioners. Nelson Castile, Ambulance Compliance Officer. I've got a short presentation here, and then if you didn't notice, I've got some really great folks back here that we'd like to bring some attention to. The final report, the final thing that happens every year is the audited financials. Those are due on May 1st, and we got those on time as we always have, and so the final report will be on your consent agenda on Thursday, along with a proclamation. This is a high-level overview. There are a lot of things that come together, and I'm going to show you a list of contracts here in just a second. On a monthly basis, you get the response time compliance, because that's one of the big parameters that they've got to meet, and that's one where we get a lot of questions, and one that takes a lot of work to make sure that we are getting what we would like. And those are always submitted via the consent agenda and then placed on the website, as well as mailed out to everybody. Right now, these are the 6 contracts that are in effect between Shawnee County and American Medical Response. The base contract that took place from the RFP processes, and then the other ones that are down there. Currently, the main base contract has been extended it was extended 5 years from the original contract, so December 31st, 2026 is when that expires. And we're already working on, through our task forces and work groups and committees, where we want to go from that point. We're wanting to do a really deep dive into that. The other contracts are up there, the nurse navigation and the 3rd dispatcher that we added in, as well as some new restrictions and requirements on the base contract, and I'll talk about those just briefly here. So the question that always that I have to answer is AMR in compliance with the contracts. Since we've added so many different contracts, I have to go through each of them and figure out what it is that we need to be meeting. Are they meeting it? Why are they not meeting it? Why are they meeting it? Are there things that we can improve upon? And I provide that feedback on a regular basis to the operations manager, who is Mickey Huber on the front row here, and he'll be glad to come up, I'm sure, and answer any questions you have. So I just want to briefly go through what we've accomplished. Fiscal year 2023 was an excellent year. It was a lot of fun. If your definition of fun is as warped as emergency services people's definition of fun is. So we, through the contract that came through, along with the nurse navigation as well as the resolutions, we saw a very good implementation of Crew Force and the Fire Mobile Act, or apps. It's lessened the workload on the 911 dispatchers. You probably heard, I believe I heard Rachel's phone go off back there. That meant that AMR got a call. It took me less than 30 seconds to pull up on my phone to see where that call is, what does the call involve, what units do we have involved. And that has been a very good addition to this system. It has helped communications in the field, as well as it has lessened the communications over the burden that we put on the 911 dispatchers when they can be doing other things instead of having to answer radio calls. We have that technology now. Ann Antrim is here. She is the AMR CES, which is the Clinical Education Specialist. I work really close with her and the other EMS officers that are on the first responder organizations. We're looking into some specific protocols. What do we want to see come out of that? Are there changes? Are there nuances? Are there things that we don't do that we want to do, and vice versa? The one that Mel Bergers, if she is able to answer any questions on, is the 3rd AMR dispatcher. AMR communications manager, Mel Bergers, they saw that we were seeing a huge increase in the number of calls coming into the center, and we'll show you that on the stats here in just a little bit. That 3rd dispatcher has, from May to December, for that portion of 23 that it was there, really helped out. You might have seen or might have heard when I discussed that for a couple months here in 24, they had some staffing that they had to take care of, so we didn't have that 3rd dispatcher. I will just say that 3rd dispatcher was sorely missed within hours of them not being able to staff that. We changed how we do the 2 free trainings that AMR is to provide every month to the first responder agencies. We have them come and work directly with Ann Antrim, the AMR CES, tell her what they want for training, and they work out how to do those trainings. We've had a lot of what we call drive-through trainings, which is just what it says. Drive your unit up there into the bay, and we're gonna work on this really quick and learn something, and they can get their hours that way. But as a compliance officer, that also makes me feel really good that we're getting some good hands-on training out there to folks that sometimes they may not all be able to get them all in one place at once. So there was also a EMT boot camp that she held. That'd be the emergency medical technicians. That's the basic life support, and I had the privilege of sitting in on a couple of those boot camps where they went through some of the common things that they want to make sure that these folks know. Some of these folks had just come out of class in less than a month or even just weeks, and so that helped to really put together for them some of the stuff that is unique to our system here in Shawnee County. The AEMT, the Advanced Emergency Medical Technician programs, the EMS officers that reached out and worked with Ann and Mickey and those folks on how do we use those people. We've got quite a few of them in the county that are stepping up to do that. The reason that they're, and I'll just go into one of the reasons that concerns me is to be a paramedic, meaning a full-blown advanced life support practitioner in the state of Kansas. You have to have an associate's degree, and we have a lot of folks that don't want to take that 18 months plus whatever it is to get that, however many hours you need on an associate's degree to do that now. The advanced emergency medical technicians, they're not a paramedic, but there are a few things that they can do that brings it up from a basic life support without having to have a paramedic. The Joint Medical Director, Dr. Keenan Thompson, who AMR pays for out of the contract. He is the medical director for all 10 first responder agencies as well as AMR, and he continues to hold office hours each month, and we track anything that we have complaints on or that we have a patient care report on, and he reaches out to those folks when those are brought forward in order to provide some feedback, whether good or bad. We've seen really good, we saw really good collaboration and cooperation. We had a cyber attack here on a health system, and that led to some really big concerns. It stressed an already overstressed system of transport, and we had folks come together to help us go through that. The radio and communications, we're seeing that it's really good now where they can talk to each other out there. Again, keep the load off of the dispatchers when the units out there have radios that they can talk to each other on. And then we've seen the participation of the different stakeholders that come together. We have been meeting often on all of the groups, task forces, and committees that you've authorized me to create, and you'll see that in the reports on the website and the ones that you get. We've created some lists of wants and needs, and like any list of needs and wants, we've got to kind of pare those down. What are the benefits? What are the costs? What are the challenges thereof? And give you some options that have been well vetted, and make sure that we have all the information available to you, and if we don't, have a way to go back and get that information. The last one is the Nurse Navigation Pilot Program. We reached the 1-year mark a couple weeks ago. We have seen some benefits from it. I'll be working over the course of the next 2 months here, getting a final report to you by July that shows exactly what it did for the system. That will also give us time and AMR time should we need to implement any changes in that program. I'll stop for any questions now if you have them. Okay. This is the second full year since the end of the pandemic. So January 1, 2022 through now, things have gotten back to whatever normal is or was or is going to be. And as I briefed a couple months ago, fiscal year 23, since this contract started in January of 2017, it had the most calls that we've ever seen in that 6-year period. If you think about a 12-month period of calls, in that 12-month period of calls, AMR and the first responder agencies ran the equivalent of 13 months of calls in that 12 months. and I'm gonna find my chart here because it's out of order. So, it says no IFT included on 2023. Every call that AMR ran that came in via the 911 system was under compliance. That included if Granny fell in the nursing home and we needed to go pick her up and take her somewhere. Even though they had medical assistance there, even though there was not an immediate need, that was still under compliance. We have removed that. We put quite a few compliance steps in to make sure that it has what it has. So if you look at, oh, I have the thing here, I think. So if you look at the end here, pretty much close on top of each other there for the no IFT, which can be deceiving, but if we add back in the ones for the IFT, that's what 22 and 23 looks like. That's a huge jump. That was really concerning. We started out January and February again here, a little bit higher than we have been. March might be leveling off a little bit, but with the beautiful weather out there, we're probably going to have another fine summer of an increase in calls. And the reason I mention that is this being the second full year, this will give us an idea where it is that we probably need to be going in the future, what type of response model do we need to put in. It will also give the communications manager and the operations manager on what they need to staff and crew out there on the field. It will also, with the AMR CES, give them an idea of how much training and additional protocols we may have to implement to make things work. It all works together as one. We have to continue to work as a team. So the on-time performance, you'll see in 2022, it was just a little bit lower there. That was expected. We didn't know coming out of the pandemic. Nobody probably could have known what the calls were going to do. We saw an increase in calls in 2022, and we saw them even more in 2023. In the fall of 22, the operations manager, the regional manager, and myself got together and saw the direction this was going and kind of put a plan together of we really need to focus on this and this and this. And so we, as you'll see later, in later reports in 2024, we're even right now with kind of where that compliance is. They are going to put on more staff. I believe we're going to have a flex truck and a couple more out there to help alleviate some of the calls. We've also got some of the portions of a tiered response moving forward that we want to put through our protocol task force group as well when they meet again in June. I'll just go to one of the popular topics that comes up. This is the fines for all of the zones. This is how many fines took place. You can see that 2023 is up just a little bit. Those other years where 20 was and 21 was, we had a lot of exemptions there because we had a lot of COVID calls, and we exempted a lot of the times where they had to spend 45 to 50 minutes decontaminating a unit. And there was a lot of calls where that happened, and we gave them exemptions on those. And we'll skip past there. So this is the audited financials that come up every year. AMR at the very bottom here, and the total continues. The reason I show these is on the second line, and I've got a pointer thing that I can do that on. Well, maybe. There we go. So this number right here, the 2.1 million, 2,127, that is uncompensated care. Currently, we do not pay AMR to provide services here other than the nurse navigation and the third dispatcher. We pay a $3,000 subsidy to AMR, and that's to make up for those that cannot pay or that they cannot collect from. That is where that comes from. So without our $300,000, the provision for uncompensated care would have been about 2.4 million instead of 2.1 million. This is their net income. This goes all the way back for the life of the contract. I would also ask you to pay attention to the very bottom line. So the subsidies they get, it's a $300,000 subsidy for the folks that can't pay. It's a $50,000 subsidy to pay Melanie to have 2 bodies in the 911 center. And then out of what they pay, when Jennifer and them cut the quarterly checks to them, they pay $40,000 towards my salary. They have to dedicate $40,000 minimum to the joint medical director's salary, and then the first responder tuition, they provide $10,000 spread across the various first responders, and it's broken out where they can get a tuition reimbursement for EMT classes, paramedic. There's been all sorts of classes that they take. This year they did have a little bit of net income there, 1.3 million. That's about a 15% return. Last year was expected. We figured it would be low, maybe not quite that low, but out of this operation, when you take just how hectic 2022 was, figuring out how to work this new emergency medical services post-pandemic, this is definitely not the type of environment that the 2017 starting contract thought that we would encounter. This is the final report that lists us out on a monthly basis. This is a report that you get, and it's also up on the website, and it will be a part of the written report at the end of the week here on your consent agenda. It goes into just how much the compliance was. I would draw your attention, and I do this on all the reports going forward. There's a new line down here that's called the IFT exemptions, and that means that if it's an interfacility transfer that previously was a part of the 911 system, then if it met all the criteria, then that one is exempted and not counted for response time or fines or anything like that. You can see that there was each month there's nearly 300, probably about 300 average interfacility there that's been taken out of the system, but that does not necessarily mean the calls don't create an impact on the system. There are still calls of that nature that they need to get there at a certain time. Before I turn it over to Ann here, do I have any questions on what I just talked about?
No?
Okay. Next week is the 50th year of the EMS week, Emergency Medical Services Week across the nation. 1974, President Ford authorized that to celebrate those practitioners. As you can see, I've got some of those folks back here with me. And so there'll be a resolution and proclamation on the consent agenda Thursday that you all can sign, and I saw Mel back there. She's probably going to want pictures for Facebook or Twittergram or whatever those things are that we put pictures up on there now. I would like to say, as the ambulance compliance officer, the accomplishment and successes that we saw in 2023, those were not mine. Those were not management. Those came because of the fire departments, our ambulance companies, the receiving facilities, our health department, and our communications folks. They all truly make up the emergency medical services system that we have here. We found out when we had the really hot weather that we had to redo how we do business. We also, as Bill Persinger discussed, we had the really cold weather that happened this winter as well. That also changed how we had to do business, and we all had to come together at one time to do that. So with that, I am done with what I have to say, but I'll answer any questions now or at the appropriate time.
Nelson, I think it's great that you acknowledge all those different individuals, but in our conversations with all of them, they also commend you every time for the amount of work that you do and the quality of work that you do. So appreciate the presentation today
Thank you, sir.
and everything leading up to it.
I don't have anything, but thanks for your effort and your time.
Yes, sir. I'll let you in.
All right, next up.
Hi, thank you. As you mentioned, my name is Ann Antrim. I'm the clinical education specialist for AMR. I also provide trainings for all the providers within Shawnee County. And one of the things that I want to talk about today, Nelson asked me to maybe have some statistics or things for you, but really I want to talk about EMS Week. EMS Week is next week, and I want to take this opportunity to talk about the men and the women who serve this county in this role, because really that's what EMS Week is about. This job's not easy. When most people call 911, they are experiencing the worst day of their lives. And our crews are responding to car accidents, to heart attacks, to traumatic injuries, sick patients of all ages. And we just have the tools that we can carry. We have our monitor, we have our medications, but really the most important tool that we carry is our mind. And that's what we try to focus on with our education. And in doing so, we talk about the calls that we've been on, and we ask the questions, what could we have done differently? Is there something we could have done better? Is there something we miss? So basically what we do is we relive the worst days of our patients' lives, hoping to make ourselves better for the next ones. In doing so, we can get lost in negative situations and outcomes without the positive ones to balance it out. So we know we make a positive impact in our community, and we hear that from our hospitals, our community partners. We get feedback from STEMI centers, from our stroke centers. We have that positive feedback, but it's really easy to focus on those difficult calls. Those difficult calls are the ones that we still see. So there have been multiple studies done about the effects of negative thoughts and outcomes and how it takes 5 positives to balance out a negative. So what I would like to ask the commission and the citizens of the county is to please, if you've had a positive encounter with one of our crews, if one of our crews has helped make a positive impact and provided comfort in that time of need, to please reach out and share that with us to help give our crews that balance, because I guarantee you they already see those difficult times, and we'd like to try to have that thank you to balance that out. And I would like to take this time to thank our crews for doing this wonderful job and putting themselves out there for our citizens. Thank you.
Thank you.
Commissioner, if I may.
Yeah.
Next Monday will be my 6-month anniversary of coming back here. And today is an apt time for me to point out that one of the things I've been impressed with is the day-to-day competence Nelson shows in this subject area. And I'm sure you already knew that, and I knew that before I got here, but it's been impressed upon me again what a great job Nelson does. I would also like to point out just a short 3 or 4 months ago, my father-in-law had a traumatic event, and AMR flat out saved his life. There's no other way to say it. He coded twice on the way to the hospital. So when you say what you just said, it's in this room. So thank you very much.
Absolutely. Thank you for sharing that. Thank you.
Mickey Huber's the operation manager, and he told me he didn't have a presentation, but he's more than happy to answer questions.
I do not have a presentation. We were just in front of you a couple months ago, so I'll say that. I wanted to take the time to thank you gentlemen for recognizing my crews and helping me appreciate them. As Ann said, as Nelson said, the job they do is a difficult one. It's mentally taxing, it's physically taxing. They're out there day and night, cold or hot, it doesn't matter. 85 times a day on average we get a call, 30,000 times a year we get a call, and they respond to it without question. And the job they do doesn't get recognized a lot. It's a very underappreciated job. So I'd like to publicly thank them, recognize them. I've got a couple crew members here, I've got a couple of my supervisors here, and they deserve every bit of the credit that we as a community can give them. So thank you all. And with that, I'll answer any questions that you do have, as I said.
No questions, but I couldn't agree with you more.
Thank you very much.
John, anything? Melanie, anything?
No, sir.
Okay. That's all I've
All right.
got for you today, sir.
Okay. Thank you all very much for being here today. This is a very educational presentation, and certainly appreciate all you do for our community. The next item on our agenda is public comment. I don't have anybody signed up. Is there anyone wishing to speak? Seeing none, any administrative communications today? Commissioner Rippon, you got anything?
Not a thing.
All right, happy Monday, everyone. We are adjourned.